Right. So before we close for the day, what we'll do for our last session is we've made some attempt. I think it was a bit blown up during the day how in depth it will be, but we did some attempt at kind of trying to bring all the evidence on zero dose together to summarize that, see if there are any takeaways that we can already frame, and then use that to set up a panel discussion where we'll dive into how we can frame some policy takeaways from what we've seen today in terms of the evidence. And so, yeah, let me kick off with that. So first, just to express that the summary was done by my colleague Kamya, who couldn't make it, so the credit doesn't go to me. So first, the summary of for which countries do we have evidence. And so we summed up all the presentations that we've seen today, as well as, so when we framed this meeting today, we put out a call for abstracts and we received many more pieces of work than we could feature here today. There's also a lot of work that doesn't have results yet. So like a lot of these evaluations are still ongoing and results will be coming in the next couple of months. But so we tried to bring that in here to provide a somewhat clearer picture. And what's not shown here is then also the study from Pakistan that we couldn't show today because the presenter was ill. So that's there we evaluated clinics on wheels, the cost of identifying children through house-to-house campaigns that Hania was just talking about. And we compared integrated outreach activities, so kind of enhanced outreach activities to a routine outreach. And just to then make a quick pitch, because it couldn't get presented today, on Monday morning at 10:30, we have another session where this will be presented. And so, yeah, very, very rich what we managed to pull together today, covering many different interventions. So what did we see from this? So we saw what we already discussed, very many different unit costs of delivery across many different strategies, even when they were kind of targeting similar areas, so rural, remote areas. We saw the cost varying from as low as $1 or not even for certain campaign approaches that were modeled out in Ethiopia, or around $2 for facility-based delivery to reach those children, and then going up as high to $130 for mobile health and nutrition teams in Ethiopia. So there's a lot of variety depending on the different delivery strategies that were used. And so what we noticed is that they also have a very different scope or scale. The number of children reached through these different interventions are not equal. And so when we look at the unit cost, the first thing we have to look at is how many children did they actually reach? And is that because of what our study looked at, or is that also just because the interventions introduced at a much smaller scale? And so what are some of the conclusions that we've seen from the different pieces of research around rural areas? So the first is that it's much clearer than for urban areas that really access, so distance is the key issue here that's being addressed, and that reaching more children drives affordability. So some of these cost drivers like transport and incentives that just get spread across more doses, and so that drives the affordability of the incentive, of the initiative. We've seen trade-offs between the cost and minimizing time children remaining off schedule. So, for example, with PERI campaigns, we saw they were very efficient, but if they're only conducted 2-3 times a year, children are essentially never on schedule if this is the only way they're being reached. And if you would scale up PERI to the extent that you would conduct it more regularly, it probably wouldn't be as efficient anymore. So that's something important to keep in mind. We also saw that many integrated delivery strategies like mobile health and nutrition teams, for example, they can provide more services, and so they're more cost efficient, maybe not necessarily from the immunization program side, but just in general for the health system. And then we saw that some initial evidence shows that drone delivery can be cost effective at the last mile. So then moving on to the urban setting. So there we saw an even wider variety of different initiatives, even wider variety of costs. So something as high as $151 for fixed site delivery in India, and then all the way down to regular outreach in Lagos being only 55 cents. And so here we noticed that the initiatives really cover a large variety of root causes of zero dose prevalence. much more varied than for the rural settings, where it's really about just distance to health services. And so that the appropriateness of the intervention really also drives the cost here. So scale in terms of what was the initial zero-dose prevalence and how many children did interventions manage to reach is still a large driver of the cost. And then, so there's a much wider range of barriers in urban areas, and so they require very, very, very context-specific interventions. And so when access is a key barrier, supply-side interventions like extended hours can be cost-effective, but it has to be what's necessary in that context. We saw that increased supply-side resources may not translate to better reach when the barriers are mainly related to the demand side. So this we saw in the Pakistan study that we couldn't show, where they blatantly introduced enhanced outreach approaches in areas where reach really wasn't the issue. And so then they don't reach very many children, and the cost per dose is relatively high. And so this requires tailored community engagement and context-specific behavior interventions. And so on to the next category. So this was our third session of the day, was around community-based interventions to increase demand. So what did we see here? Also a large variety in different types of interventions, different types of costs. And here as well, scale played a big role in what might be driving some of those cost differences. And what can we take away from this is, so these kind of interventions can be very effective at tackling deep-rooted demand-side barriers. That was clear. There are also very high design costs involved. And so the cost per zero-dose child could go down as more children are reached and design costs are amortized. But redesign might be needed to actually scale it. So you would almost have to go neighborhood by neighborhood to really know, is this intervention the right intervention in the right place? And so can we really scale it? Are we really able to amortize on these design costs? And so, then to the last session on tackling financial barriers, lots of discussion. So we noticed that the financial burden on caregivers can be significant. Effectiveness of cash incentives varies, is what we heard. And the most promising are targeted immunization-specific incentives in a high zero-dose burden areas. And the design delivery method and amount given impact effectiveness, context-specific design is needed again. So this is what we heard today. And then house-to-house identification of zero-dose children. So this is part of the study that we actually didn't get to present. But the conclusion here was that it takes quite a little bit of extra time for a health worker to identify zero-dose children, but it comes at zero financial cost. It's government-driven, government-led. So from a sustainability point of view, it's great. But it has to be coupled with good data systems. So if there's a huge burden in transferring over that information to the EPI and the follow-up doesn't happen because of that, then the system fails. And in addition, of course, even if that identification is very successful, it's only as successful as the EPI program finally is in actually reaching those children afterwards. So what can be some of our preliminary takeaways based on what we've seen today? So reaching more children drives affordability, so that we've seen very clearly. In hard-to-reach areas, there's a huge trade-off between the cost and the minimization of reaching children on time. In urban areas, the suitability of the intervention, given the causes underlying zero-dose in the first place, drives the number of kids reached and therefore also the cost. Co-delivery strategies are effective at reaching zero-dose children and can run at a low cost per service delivered. High design cost may go down over time, but likely won't decrease with scale, as different contexts require different approaches and therefore redesign. Targeted conditional cash transfer schemes in high zero-dose burden areas could be effective at reducing financial barriers. And finally, high variation of cost across districts and facilities, underscoring that what's cost efficient in one location might not be cost efficient in the next. So these were some of our preliminary key takeaways from today. And then we would like to invite all the panelists to come up here and discuss with us what their takeaways were from today's session. And then we'll also open it up for the audience for everyone's questions and reflections from today. Thanks. So can I please invite Todi Mengistu, Carol, Kamya, Turab, and Logan Brenzel on stage, please. Thanks. So maybe for the first question, when you answer, please also introduce yourself so that we have that covered as well. And so I think we wanted to start off this panel discussion by asking each of you which intervention jumped out as the most promising to you, and then given the evidence presented here today or other evidence that you will have seen. And so what should be our recommendation for countries in terms of what strategies they should use more of, or which strategies they should just be abandoning?
Good afternoon, everyone. My name is Kamya. I'm a health economist in Uganda, working with infectious diseases research collaboration. To the first question, I'm quite hesitant to answer because one shoe doesn't fit all. But some considerations could be one of the gaps I have identified just listening to the different presentations today is there's less emphasis on identification. So some of the interventions need to be focused to identifying this child. For example, in Uganda, as I previously mentioned, we don't know where this child is. We don't know what their name is. But in our context, the registration process helped us map out where these children are, the hotspots in which they are. And before, the Ministry of Health had tried to do this through triangulation on different data sources, but it just wasn't working because at the end of the day, you need to know the name of the child, where they reside, so that you're able to give them the first dose and actually help them complete the immunization schedule. So my answer is going to be a bit vague because one, we need to identify the child. But in terms of reaching, it seems that from the presentations we've had, some kind of campaign-based programs would work because they seem to decrease the cost. And this could be also coupled with targeted outreaches.
Hi everyone, my name is Turab and I'm the Director of Global Health at PC Global. So a lot has been said, and I think that we need to integrate the cost data coming out of these zero specific strategies in the light of fragile last mile contexts. So we do see that the costs are relatively higher than the routine fixed site or the outreach service delivery. But I think before we comment on the cost, we need more data, we need more research to estimate the long-term economic benefit. We need modeling to see that how this immunizing zero-dose children would add to the productivity, to the education of these children, because each child vaccinated is like one life saved. So having said that, for the countries, there is an increasing need to identify those high priority, high impact settings where they could employ these interventions. So earlier on in one of those presentations, and then now very recently, Laura mentioned that these interventions would have varying costs in different contexts. So we need more research. We need more implementation research maybe to see that what would work in which context, which setting. For example, a strategy may not work very well in urban areas, but could be very, very useful in rural areas. So clinic on wheels per se could be one example of this. beyond that, I think one of the strategies which should be increasingly adopted, replicated, and taken to the scale is integrated service delivery. So with the increasing focus on universal health coverage, I think we need to use all these service delivery platforms which are there in the public sector. And then one thing which was missing, because whatever I'm saying is what I heard today or what I saw today, one thing which was missing, and maybe Logan would agree to that, is private sector engagement. We have not heard a lot about that coming out of the evidence from these interventions, and I think that is one huge missed opportunity, because even at the GPs, a lot of children died along with their parents, and similar is the case with adults and girls if you're talking about HPV, because Pakistan is rolling out HPV in the next 2 months. So there you go. I mean, if you are not engaging something which is already there on the grounds with minimal incentives, which would be much less than what we saw here today, then I mean, you are missing out on one of the potential zero dose strategies. So I think I'll just end here, and then maybe Logan or Todi would like.
Okay. So I'm Logan Brenzel. I'm formerly with the Gates Foundation and currently a consultant. I think the question that was posed, which intervention is more promising, I mean, obviously there's a wide variation in the results that we've seen. And that variation is driven by the methodology, the volume, the context, the interventions, the density of zero dose children. So it's really hard to say. But I would say that I don't think it's a question of selecting one intervention that stands out, because I don't think all zero dose children are the same. They're not zero dose for the same reasons. And so I think we need to start thinking about the complementarity of different interventions. I think it's clear from the presentations that the routine system is not very good at reaching zero dose children. I mean, you look at the number of children that they would reach on a normal basis, it's very low. So we do need additional kind of efforts in place to be able to actually reach those. But some of them would be supply side interventions to solve access and maybe readiness problems. But I don't think we can solve everything with a free health care service and insurance type programs, because we do have all those demand side issues, and those feature very prominently in some contexts. And so I think the complementarity issue is really important, and maybe start thinking about maybe packaging different types of interventions together. So.
Hi everybody, I'm Todi Mengistu. I'm with Gavi, and I manage our work around health and economic impact of Gavi vaccinations. So just to say, first of all, it's really, really great to see all this work that has happened over the last couple of years. I remember when we were working on the Gavi 5.0 strategy in 2019, we couldn't find any papers. There was one paper in India that Logan had funded looking at the cost of zero dose, and now we have all this body of work. So it's really congratulations to the community, because I think it's really something to recognize in, I mean, relatively short amount of time, how much we've gotten on the works. So just wanted to first start with that, because I do think we need to stop and acknowledge our big wins. That said, in terms of what came out for me, not like others on the panel said, there isn't one specific intervention that was the winner, but I do think what came out really strongly is that we need to first identify the root causes of zero dose, and that interventions need to be targeted to those. To those, in order for the actual intervention to be successful and reaching those children, and also towards reaching the most children to get to the efficient intervention level. In terms of what I think was missing, at least for me, in terms of the body of evidence, is really the dynamic view in two ways. The first one, I think Alex alluded to it in his presentation, is the definition of zero dose. I think when we came up with the idea of zero dose, it was about linking children to routine systems and making sure that they get the full schedule through those systems. So it's really it's not just getting that first dose, but really following through that child and seeing how many of those children actually get the full schedule. So that piece, I think, is missing a little bit in what we're seeing come out. And the second piece is really the year-on-year type strategy. I think, Brian, to your first question during the first session, it was really about like, okay, so this year you do a period, say you get all the under fives, but what do you do next year? Because then you have a situation where you're not, if you can't really do a period again, you have to differentiate your strategies over time as well. So yeah, I'll stop here.
Thanks. So now I just want to turn it over to the audience for any questions or reflections from the rest of you.
Thanks. I think picking up from the last part, to me, in the presentations in the early part of the morning, I struggled with what was being defined as a zero-dose intervention. So from the zero-dose framework, we know identify, reach, measurement. So I was struggling in terms, because if you talk of, as Carol was talking about, an intervention to identify, like that's clear. So that one can say we costed an intervention which identified. But at times when we maybe are combining a set of other strategies, then it's not clear how we're differentiating how this is zero dose and this is not zero dose. So that was a bit of my struggle in terms of the early part. But then I liked, I think, the community, the demand session, because there was a bit of clarity in terms of how the intervention, you could see an intervention. So I was struggling to differentiate routine versus zero dose. And I know it's not good to try and look for boundaries, but I was struggling to find the boundaries, methodologically, especially if you want to do costing. And that's why I think the recommendation by Prof. Bishai was good around thinking through the methods. So Logan and team have done great work around the frameworks of what are the functions, what are the line items. And a lot of that can be borrowed because I know we keep telling ourselves as a community that we have methods, rapid measuring methods, but I think there are some things we could be able to do around these interventions that we're calling zero-dose interventions. And some of the struggle we're having in our teams as we think through intervention is where are the boundaries or what counts as a zero-dose intervention. So a bit of being clear, I think, is, and my recommendation there is a bit of some more methodological work to try have clarity around what counts as zero-dose intervention, but also spelling it out whenever we are doing this.
Okay, thank you. For the question, reaching zero-dose children, you mentioned the public-private partnership, and I agree with that. Because let me take my country as an example. Majority of women prefer private hospitals in my country for maternal and child care. But when you look at this, and I know that private-public partnership is recognized in our health policy. But if you look at practically, if you look at the structure of immunization services, you see that what the primary health centers consider is basically the public primary health care facility. Maybe in principle, they're supposed to consider private. But if you can bring it down, we structure it in a way that at local government level, we have immunization officers. At health, road level, we have focal persons. Those focal persons, if they are looking at both private and public health facilities in their own domain, then that will help us to actually reach these children, because they go to private hospitals and they leave. And that is why maybe even if there is a need for training or anything, it is all about those in public PHCs, health posts, not private. But they can tell you that in those areas where they have public PHCs and health posts, they may have up to 10 private hospitals. And those private hospitals, they have their children, and we don't even know how they get their vaccines and all that, because the structure of that vaccine management has not really captured private hospitals at the lower level. So I think that public-private partnership is key to reaching this, and we can continue with the normal routine immunization and outreach, because normal routine immunization covers outreach and fixed post. But let's just cover the population. The population is not covered. Thank you.
Yeah. So my question comes from two theories, maybe that's one from economics and one from, let's say, vaccinology. Vaccinology being the concept of herd immunity, and from the economics being the law of diminishing marginal utility. As in, the zero-dose children in our context, in the Indian context, is the last 5%, maybe last 3%, 4% children. When I'm looking at from a vaccinology perspective, the herd immunity is, we talk about, let's say, 95% coverage. We can talk about leave the 5% with the herd immunity concept. And from an economics point of view, the law of diminishing marginal utility, as in where does the buck stop, as in, or how far should we be willing to pay to reach this last zero child? So this is the question that frequently the policymakers, when we talk to them, they ask. So any thoughts on that?
Okay. Thanks. I'm Todi panelist. I think we do have various contexts of how we kind of explain what zero dose is. Our panel from the Gavi, I just mentioned that the zero dose thinking really is a child that completes the schedule, right? Some context, people had historically seen zero dose as the preliminary vaccination, right? If a child is able to receive the first set of vaccine, the child is out of the zero dose coverage. So that now leads me to our global thinking. I think I also encourage our team that's leading the immunization economics to have more global understanding and research when it comes to this zero dose in particular. Right, so there's a one frame that says, and if we begin to call zero dose that as a full schedule, we begin to get more results. Because if we do the preliminary vaccination, that's a different strategy. We go into the popular vaccination, we begin to look for more people with a different strategy. But if we all agree that zero dose is a full complement, if you're not having them all or nothing, we begin to see a proper trend of how we are gradually getting immunization right. So there's a one strategy, there's a one financing strategy, there's a one vaccine financing strategy, there's a one immunization strategy. I would also encourage, if there will be more sessions in the coming years or months, to have this global calling of countries where we all sit down to discuss what zero dose means to us, what are the global framework we want to have. So countries will begin to measure with that, to say, okay, if we're able to calculate this, we are at this point in the next couple of 2 years or at this point based on population increase, based on target. So countries gradually work towards those towards those frames. So in any other congress we're having, when we come and we're discussing, countries are presenting, we started this way, this is where we are, and in the coming years, this is where we plan to be. So there's that global coordination. Thank you very much.
Thank you. I think we want to move to the next question for our panel. So we've talked about what we think is most promising. Sorry, what's your story? Oh, sorry. You can go first.
Thank you so much. I wanted to add a quick question to the panelists. I know we had a lot of evidence from the Global Polio Eradication Initiative on the cost and the cost effectiveness of doing eradication, and I wanted to ask how those costs compare with the costs of zero-dose agenda in terms of reaching the hard to reach. Thank you.
All right, maybe then first some reflections from the panel. I think there are only 2 questions, the rest were comments, but go ahead.
I don't know the answer to your question, Sachi. All I know is that eradication, the return on investment was infinite, so that's the only number I remember. But it's good to look into that, and I think it was interesting that several of the studies had looked at using polio workers to help identify and leveraging that program, though unfortunately I'm not quite sure that the program is going to continue. So that's also a risk involved in that. There was a comment about maybe needing some more methods or guidance. There is some guidance up on the website already about kind of approaching, how would you approach costing and evaluating a zero-dose program. And it's not super detailed, but it does kind of go into issues around boundaries, around perspective, scope. What I found, because I'm advising the ZDLA teams in their work, is that although we have kind of a standard methodology, it has to be customized to every single situation, and also kind of how the different interventions are taking place. So it might be quite difficult to have like a standardized guideline, but we can take a look at the first cut of our recommendations and see if there's any areas that we need to elaborate on. That would be a way forward.
Okay, then, okay. So then the next question for the panel is, so we've looked at the interventions, and so based on all of this evidence presented today, what would be our recommendations for donors? So we know that also donors aren't as lavishly funded as they once were, and that the zero-dose agenda is somewhat at risk. And so, first of all, what would be our recommendations for donors based on the evidence that we've seen today? And second, do we have enough evidence, or are there clear evidence gaps left that really need filling first? Over to the panel.
Right, so I'll just go first. So I think I've mentioned this before as well as answer to the previous question. I think for the donors, they need to pump in a little more money. I won't say a lot more, a little more, so that we can see the long-term economic impact of these zero-dose maybe selected zero-dose strategies on the long-term development potential of each child vaccinated through these strategies as well as the education. So that is one of the recommendations. Thank you.
I can add to this. I think another piece that came out was also integration, and so that means cross funding across the different donors that look at different things. Currently, we're very siloed in the way we approach things, but I think there is scope to integrate with nutrition and any other types of poverty reduction. And the last one, the cash transfer, the CCTs. So there are a lot of scope to integrate, and that may be that's a better way to enhance efficiency across the different donors by pulling our resources together.
Yeah, well, I could maybe touch on Alan's question about kind of, are we really reaching 100% coverage? Is it economically worth it? And particularly in the, maybe current context of waning donor support and also the financial constraints that countries are facing. And of course, from a humanitarian perspective, I would say yes. From an economic perspective, I'm not so sure, because it's clear to me that several of the interventions, have a high cost per child reached. Maybe that child or that community have never been reached before with health services. So, maybe there's a way to sell that in the sense that you're hopefully bringing that community more in touch with health services, and there will be other benefits to that. And in this case, I was thinking about your comment about mobile teams and kind of those integrated, ways of servicing, areas that are hard to reach. But I do think it is the question, right? Where to put our resources, and if it's worth it to do it, to invest in potentially higher cost services to reach everyone.
So a lot of, because the previous question was what was missed. So one thing, I think there's been research done, but may not be very recent, that if we go to the WHO definition, it's one vaccinated per 10,000, right? So that is not in these last mile fragile contexts. It's never there, right? So most of these vaccinators, they are vaccinating much more than that. So one thing could be, having more HR as a zero-dose strategy, and then comparing the comparative cost of numerous zero-dose strategies in different settings, urban versus rural, last mile, etc. I was just thinking.
Yeah, and just to add on to what has been said, I think integration of interventions is key, and also leveraging other programs, health programs, might help. And of course, I would encourage the donors to push for integration, because this can help answer the sustainability question to some extent, even though the interventions would have to be studied in order to prove that they're sustainable. Another thing is about, I found that the patient perspective hasn't really been looked at, and yet these the caregivers actually might incur cost in terms of accessing these very innovative interventions. So perhaps that's also something that researchers should note, and if possible should consider in terms of future studies. I think that's it for me.
Thanks. So maybe back over to the audience for additional questions, comments, reflections. Yeah.
Thank you. Hi, my name is Anita. I work for the Clinton Health Access Initiative. Maybe I have more of a comment, but I'll try to frame it as a question. So, coming out of the COVID pandemic, when countries were preparing to recover from immunization backsliding and planning the big catch-up, one of the narratives that came out was, can we use zero dose as an entry point for catching up? So here in Indonesia, the Gavi middle-income funding was positioned as a zero-dose funding, but that could be the tide that lifts all boats, and you would catch a lot of under-immunized children and missed communities. And I wonder if or how can we position other externalities that come from zero-dose interventions, either strengthening community demand or engaging community health structures, as a way that we measure and say that there's more that we gain out of zero-dose interventions beyond just reaching the children?
Thank you. Hi, I'm Catherine Pitt. I'm a professor at Health Economics at the London School of Hygiene and Tropical Medicine. I think that last point of zero dose as an entry point was a great segue to some of my comments about heterogeneity and that the interventions need to be different in different places. I'm not sure, zero dose sounds like a great entry point, but you wouldn't stop only at the zero dose children. You would go to the other children in the household or in the area. But I'm not sure that, I think a lot of these issues are captured in standard training on how to do economic evaluation, and so there's some things that I haven't heard talked about today that I would have expected to hear, like talking about the downstream costs. You were touching on them perhaps related to the patients, but also for the health providers and not having to pay to treat the diseases. That's standard and should be included in any economic evaluation. I'm wondering with some of these what the decision problem is that you're trying to inform. Are you looking at generating total budget estimates to see what is affordable and what's not? Or are you trying to look at efficiency? In which case, I'm surprised that equity isn't a word that's, obviously that's like the underlying principle behind zero dose, but it hasn't been talked about today. But there are lots of frameworks and a whole bunch of sessions in the week to come about equity-informative economic evaluations, which offer a framework to look at the trade-offs between equity and efficiency and to give decision makers the possibility of really understanding them explicitly. So I think it would be really helpful if you thought about that kind of framing rather than trying to put up a cost per dose delivered against a cost per dose for children who are easier to reach. And the very last thing is that the consequences of vaccinating a child who is hard to reach, there are probably other reasons to think that the consequences would be really different. They potentially would have less access to care and therefore more likely to have really bad outcomes. If you're not taking that into account in your disease modeling, you're underselling the health value of vaccinating those unreached. Just a bunch of reflections there and things that I hope you take into account.
Thanks. Question back there.
Yeah, thank you. I'm Sahid Neman from our University Karachi. So I just wanted to share a perspective that, we are implementing a project in Karachi that is looking at zero dose, funded by initially Gates Foundation and now Gavi. So when we looked at, where are these zero dose children, and we conducted a GIS mapping of the mainly refusers and the zero dose. So we found that there are, serious, coverage gap. So we found that these children, are there where there is informal system like, traditional containers, even in Karachi, which is metropolitan city. So when we correlate this, so how to tackle this? When we are just, using language of zero dose, and we see that there is a lack of demand for immunization at the community level, especially at the last mile. And if we package, interventions as an integrated service delivery, because a mother is really worried about the nutrition of her children, as compared to, immunization, which she may not see, a benefit, health benefit, because her, level of, looking at health is different. Her way of, internalization of the interventions as immunization versus, something that she can see that is helping her child to grow healthy. So we have to look at, even from economic side, if we just focus on zero dose economics and versus, integration, which will give you, more good outcomes. So in this project, we specifically looked at why are we not making progress, because we are mainly focusing on immunization and vaccinator. When vaccinator visits a household as an immunization worker versus a health worker, the acceptability is quite low. So we have to think out of box, that how should we package interventions from community perspectives. As a scientist, we may use, frames differently, but from the community perspective, they see health differently, specifically the last mile population, where they are trusting more to informal health system. So this may be an opportunity for us to package interventions differently, so we bring them to the formal health system. Thank you.
Just follow up to Zach's comment. My name is Imran and I work with PSC Global in Pakistan. Yes, zero doses as entry point, but we have to also understand in countries like Pakistan, the dropout rates are also very. I think what we are focusing on is the benefits of immunization. And if a child has not received 3 doses of pentavalent or measles, or 2 doses of measles, then probably we'll never get the benefits. I mean, we may calculate cost effectiveness of reaching 0 dose, but I don't know if there may be an area where we have to look at the next steps as well. Focusing on 0 dose definitely is an entry point, but I think if you're focusing on the economic benefits of vaccination, then timeliness and completion are 2 major factors that need to be taken care of.
Thanks. Other reflections from the audience? Now we can turn it back over to the panel. And just to add on the integration component, so this is something we've seen in Ethiopia as well, that the immunization program actually benefits from much higher demand for nutrition services than there is for immunization. So it's not only the efficiencies of integrating, but indeed also the just leveraging that higher demand for other services that are maybe more directly visible. I would just say I completely agree with the person that suggested maybe we need to. One area of future work really should be around the full economic benefit of vaccinating a 0-dose child or reaching a 0-dose household, and I think that wasn't the mandate for a lot of the work that was presented today. I think as far as the ZDLA work, we were asked to estimate the cost. So this is why we're reporting out. And a lot of the teams didn't necessarily have that expertise on board. And so they've really worked very hard to do this on their own, which I think deserves a lot of credit. I think another kind of gap is this whole dynamic, the dynamics of reaching the 0-dose children, and kind of the dynamics around, measuring this at one point in time versus seeing what happens more downstream. And as we reach more and more children, does it become cost prohibitive to continue? So what is that point at which we might have second thoughts?
Yeah, just to add to that, this is a question of sustainability. I think it came up a few times, even with things smaller scale, like startup phases. But as this goes forward, that is a big question, and we do need to think about the trade-offs to some extent between IHEA and sustainability.
Holly, Carol, anything to add?
I'd just like to respond to that great question and the point well taken. So I think you missed the presentation by Hania, our colleague from Emeritus, and the interventions they are testing in for the 0-dose. I think the 0-dose learning hub project. One of them is using the cash incentives, which is basically leveraging the opportunity of conditional cash transfer from this program, and then also using these. She used the term informal clinics, which do include TBAs, as the 0-dose strategies. So it will be worthwhile for the results of that project to come in, because I think they have shared preliminary data, but great suggestion there. Thank you.
Thanks. Over to the audience for any other questions or comments. Mark?
Thank you. It's been a really rich day from all the presentations and a great panel today. And just some sort of reflection, and also really interested to hear panel's thought. I mean, from the comments everyone has made, I mean, and the presentations, I sense that, you know, there's been a lot of sort of like empirical data collection based on particular implementations, and that's been incredibly helpful, because we heard just a few years ago there was almost no data in the field, and before we can make knowledge we have to collect data. But maybe what I'm hearing is now we're at the stage where we need to take a step back and start asking the sort of bigger questions, like, you know, can we come up with a taxonomy of interventions? Can we match those types of interventions to reasons why, you know, there are zero-dose children in different categories? Can we then create investment cases for each of these sort of maybe matches between the interventions and children? And a lot of this might not actually cost a lot to do. Some of it might be bringing all the people who've done the work into a Zoom room because they have a lot of this knowledge. Some of it might be some analytical work. But the next stage after that might be then generating the manuals and the guidelines from all this knowledge that has been created.
Thanks, Mark. Anyone else?
I agree with Mark that the word interventions comes to play, but then that asks the doer of the intervention. And you know, we're moving off of this global donor-financed initiator of the doer of the interventions into a country-initiated executor of the interventions. That's exciting, and it means that the one who owns this problem is close to those zero-dose areas. To me, they look like a local health department. That's honestly the one who owns the problem. It's the health officer for this place. And they're the ones who need the interventions. And we've, so many times we're saying, oh, the owner of the problem is global philanthropy, or, you know, no, Gavi doesn't own this problem. The owner of the problem is the responsible health department. They're the ones that we're supposed to have the list of the zero-dose children that Carol says we need as a fundamental tool in a rural setting. So let's put them into place. We're going to do interventions, and we're going to write them in our journal. Don't write them in our journals, but let's identify this moment where the country, local leaders in health departments, the public health officers own the problem and hold them accountable for reading these interventions. And we can show how it's not just cost effective, but it is a builder of resilience to have a list of the zero-dose children, because they're also the ones that are going to do the most dying. If you want to move under 5 mortality down, that's where you start. And it's not just on vaccines. They are the ones who are stunted and wasted and malnourished, likely to miss school. So this is the list that every health officer has needed. And as long as we say, oh no, this is vaccine, EPI, we're in our little silo, and not helping this local health department do the 360-degree work that we've sort of pushed away with the typical fragmentation of global health, malaria, TB, vaccinations. You know, we keep doing this and doing this. Now, post-colonial global health, we have an opportunity to put back the countries as owners of this, as well as other problems. The zero dose is just a marker for a very vulnerable child across a variety of issues. And yes, it's coming from a vaccine world, Gavi funding today, but it is this basic problem owned by the community to be solved with assets from wherever they can get them.
Thanks, David.
Thank you. My name is Emilienne Biemendi from Chai Cameroon. Since I've been in public health, I hear this integration aspect. It looks like we have a solution, maybe the best solution, but it never happens. I don't see it happen. We talk about it, we suggest, we recommend, but do we have any effective step that we can follow to put in place the integration? Because, for instance, in Cameroon, there is integration at the operational level, because the same healthcare worker who is doing vaccination is the one who is doing malaria and so forth. But when we go up, then we see that we're working in silos. So we have the solution, but why are we not pushing for that really?
Thanks, that's a great point, and I guess it goes to David's question as well about it shouldn't have been a zero-dose problem to begin with because that's vaccines only, but if we would have framed it as we just push all these indicators all at the same time in an integrated approach, who would have funded it, right? That's the other question. Other questions from this side? Back over to the panel.
Just to the question of whether integration actually works, how it can work. I think this is context specific. I mean, there are certain opportunities that the country can leverage on. For example, in Uganda, we recently introduced the malaria vaccine. So that involves 2 programs. So what we've been pushing for is for the malaria program to work with the immunization program. So I'm not saying this is a solution for all, but it creates a foundation for that collaborative partnership between the malaria program and the immunization program. And what we've seen, especially the malaria program actually liked the idea of house-to-house registration, and so they have modified it, the tool, to include some malaria indicators. So it's promising. It's promising. I'm not saying it's easy because these programs have different funders and with different interests. But perhaps that could be a start for leveraging on other programs. So what we've seen is that now they are going to pilot that registration tool to include both malaria and immunization indicators, and I think they're working towards updating it over time.
I can also speak to the integration question. So this is something that we have struggled with in the past, but malaria is a good example. It was previously fully a global funding, and now I'm talking about the global level. The interventions were being funded by the Global Fund, and Gavi came in with the vaccines, and now we are working quite closely with the Global Fund, so that's also happening at the global level. It's nascent, and there's a lot of challenges to work around, but it is happening. And increasingly, as the constraints, there are more resource constraints at the global level as well. It's a push for the funders to work more closely together, so I suspect that will be happening more as well. And there's also the Lusaka agenda, which is one of the key aspects that is asking funders to work more together. So I do think that's going to happen more systematically going forward.
All right, any last questions from the audience? Then I would want to ask every panelist for a final reflection on how do you see the agenda for zero dose move forward? Like, what are our key next steps? And how can we fit it into this new resource-constrained environment that we're in?
So, my take on this is that other than the recommendations coming out earlier on from the audience as well as the panel, including the synthesis you have done, Laura, the need for more research is there to identify those right approaches, the right strategies for the right populations, for the right context. But the good part is that if we talk about the evidence coming from Pakistan, that there is recognition of this problem at the country level, because the three approaches we costed out, they have been adopted at the national level, if not national, then at the regional level. So, I mean, there's a lot of evidence already there on the effective strategies. And before zero dose, it was under-immunized children. And my colleague Imran, he spoke about the missed opportunities as well as the timeliness. So before zero dose, those were the questions, and we all were doing research on those questions. So I believe a lot of evidence is there. So now there's time for the enhanced advocacy, taking that evidence to the countries even coming out from these initiatives. There was a zero dose learning week last year in Geneva. There was a lot of evidence which was synthesized from the publications that were submitted globally. I believe we need to strengthen the apparatus at the country level so that increasingly partners such as us or the UN partners should be talking to the government to take up on that evidence and own it and roll them out at scale.
Yeah, I think, clearly some of the evidence presented was very preliminary, so I think those studies need to finish, and I think we need to maybe look at the data again, look at the ranges, try to kind of make better sense out of what all that data is telling us, and whether we can make some recommendations on greatest value for money for different contexts or different types of interventions. I think it would be worthwhile to take a look at our recommended methods and maybe update them a little bit. I do also think that it's might be worthwhile to do put in place some more kind of evaluations of the full economic benefit. And I also think that some of the interventions that were presented haven't yet, they're being done on a very micro basis, and so the question is scalability and how will the cost change maybe with the scalability, or what would be the cost for the government and how might that be sustained within the government context. So there are a lot of outstanding questions. We've really just, kind of taken the first step, but I think we have a lot of data and information by which we can kind of explore more in the coming months. Thanks.
Thank you. So I echo all the points that have been said already. I really like the idea of the taxonomy. So there's been a lot of data generated, but we need to try to structure it in order to be able to find recommendations that could be useful. I also do think this question of sustainability is an important one, and for each of those different interventions, we need to understand how sustainable are they once they get to scale. And even looking at things if we're thinking, okay, the countries need to take these over, given the current constrained financial space, then we also need to start thinking about analyses like budget impact type analyses to understand how this is going to be reflective of whether government can take this over fully or not.
Yeah, you just said what I was going to say. But maybe in my own words. The key things are, at a country level, we look forward to participating in refining those methods, but also using them for costing other zero-dose interventions, because at the moment there are so many being piloted, and so those would be timely at country level. Secondly, of course, is to look at sustainability. I think that is a key theme for this session, to make sure that or to comment on the sustainability of these interventions for future for donors, but also for in-country stakeholders. But thirdly, knowledge translation. So much as we produce evidence, we need to engage the stakeholders to understand it, but also use it for planning and budgeting.
Thanks. So just a big thank you to all of our panelists. So then just very briefly as we close, so tomorrow we'll be talking about financing sustainability and donor transitions in the morning, and then we move on to vaccine portfolio optimization and prioritization in the afternoon. So two very super important topics for tomorrow as well on the agenda. So please be here again 8:30 sharp. Thanks, and have a great evening.
Thank you.